obesity and its impact on different health conditions. First, we need to accept that obesity is a disease. It's not just a problem of appearance. It's not a cosmetic issue, but it's actually a disease. Last week, we covered obesity and its impact on bone health, where we had eminent orthopedicians. Today, we are covering another topic, a very crucial topic, that is the impact of obesity on health of women, that is PCOS, infertility, pregnancy, and cancers. Today with us, we have eminent obstetrician gynecologist from Mumbai. We have Professor Dr. Durusha, Dr. Kiran Coelho, and of course, we have the Director of Center for Metabolic Surgery, the bariatric surgeon, Dr. Raman Goel, with us today. Each of them will be talking about different aspects of obesity and its impact on women's health. So the first speaker today, I would like to introduce Professor Dr. Durusha. She is the Director of Gynac World, the Center for Women's Health and Fertility in Mumbai. She is also the founder president of the PCOS Society of India, and she's a consultant gynecologist, fertility expert at many of the premier hospitals in Mumbai like Breach Candy, Jaslok, Hinduja Healthcare, and so on. So, Dr. Professor Durusha, over to you with your first presentation on the impact of obesity on polycystic ovarian disease and infertility. Doctor, over to you.
Thank you so much. Thank you very much for your kind introduction. I'd like to start off with the beginning of my presentation. I think it's not showing up. Just a minute.
Yeah, they should be putting it on.
Just a minute. Okay. So, okay. Can you see the slides, please?
Yes, ma'am.
Yes,
please go ahead.
So I'll go ahead. I'm going to be speaking to you today on the impact of obesity on PCOS and infertility. I'll be focusing my attention on infertility, but I'll be bringing up the issue of PCOS and why it occurs, etc., and what does it do. I would first of all like to thank Dr. Raman Goel for having invited me to speak to all of you, and it is my pleasure to take you further into this presentation. Now, again, my slides are not moving, please. So first of all, we talk about how do you diagnose PCOS? Most of our patients come to us with an ultrasound report talking about, I have PCOS, doctor, what do I do? Now, they make that decision only on the basis of the ultrasound report they see. And that ultrasound report is talking about polycystic ovarian disease. Most of the radiologists are writing polycystic ovarian disease, which today we don't call it as polycystic ovarian disease. We say it is polycystic ovarian morphology. What that means is that the ovaries are looking polycystic. And that does not mean that the girl has PCOS. If you have to label a girl as having PCOS, she should fulfill two of these criteria. And these are called the Rotterdam criteria, wherein the first one is where the woman should have irregular periods. The second is she should have either a clinical appearance of extra male hormone in her body, or the blood level should show high androgen levels. And the third is that she should have polycystic looking ovaries on ultrasound. If any two out of these three criteria are met with, then we say that the girl has PCOS. At the same time, we must include other issues such as thyroid disease, hyperprolactinemia. We must also rule out congenital adrenal hyperplasia, because all these conditions could also mimic the similar problems of irregular periods, hyperandrogenism, etc. So this is how we would do a diagnosis of PCOS in terms of doing the test and a clinical examination. Now, if you look at the pathophysiology of PCOS, why does it occur and what happens with it? This looks like a very, very complicated graph, but I'm going to make it as simple as possible for you. There's something what we call insulin resistance. What it means is that the woman is producing insulin in her body to bring down the sugar levels, but for some reason that insulin is not able to bring on its effect, and that gives rise to insulin resistance. When there's insulin resistance, the body goes on producing more and more of insulin, so that insulin will then, sort of cause its effects. So the insulin levels go up in the blood, and this is all a pre-diabetic state. This insulin resistance you will find even with obesity. So obesity adds on to the problem of insulin resistance, which is occurring because of polycystic ovarian syndrome. All of this leads to high insulin levels in the blood. These high insulin levels act on the liver and reduce the production of sex hormone binding globulin, which is a protein to which androgens or testosterone will connect with. So if the sex hormone binding globulin is low in the blood, the androgen which will attach to it will be much less, and there'll be extra androgen floating around in the body to bring on all its effects of male hormone excess. So this is how one sort of pathway in which insulin resistance causes a problem. The second issue is when the insulin is high in the blood, it also acts like a growth factor, and that itself can cause obesity. That itself causes problems on the ovary, where the ovary, sort of the theca of the ovary gets hyperplastic, it overgrows, and it starts producing more and more of androgens, and it also increases the level of luteinizing hormone. So we have a situation where there are so many pathways based on which the androgen levels are high in the blood, or even they may not be high, but they may give clinical effects of hyperandrogenism, by which we mean they can get acne, hirsutism, loss of hair from the scalp. Now the question is, does hyperandrogenemia occur first and then causes insulin resistance? Or is it the insulin resistance causing the hyperandrogenemia? There is a little bit of a conflict on this, and there are various, various researchers who have different opinions on this. Until today, we have not reached a conclusion as to what occurs first. So this is where we are talking about, just a minute. Yeah, we are talking about clinical presentation of women with PCOS. Now, women may have PCOS right from the time they have puberty, because this problem starts only when the ovaries start functioning. And when the ovaries start functioning, the girl develops, she gets her puberty, and then starts the phase of adolescence. This is the time when she can get menstrual irregularity, her periods get irregular, which can be a normal occurrence in a young girl in the first 2 years of her menstrual or reproductive period. At the same time, she has cosmetic concerns like acne. She may develop acne which occurs. She may develop hair growth on her face, which may be in areas where normally men have hair, where women don't have hair. That is the upper lip, the chin, the midline of the chest, around the nipples, upper abdomen, lower abdomen. And these hair are not the natural thin hair, but they are thick hair like you would see in a man's mustache or beard. So that's the hair we have to look for, and that's what we call hirsutism. She can also develop hair loss from the scalp, not from the body, but from the scalp. And she will have, combined with it, is obesity. So this is during the adolescent period. Now what happens is in the first 2 years, there's always a little, the maturity of the hypothalamo-pituitary axis has not yet occurred. And hence that menstrual irregularity can be related to that, or it can be related to PCOS. And since there are so many issues which are common between puberty and PCOS at that age, we do not make a diagnosis of PCOS at least till the girl has finished 8 years after her period. 8 years after the period. So if she's had her period at the age of 11 or 12, we don't make a diagnosis at least till she's 18 years old. And if the problem continues, then we may say that she has PCOS. Prior to that, we would say she probably has PCOS. So that's one thing we need to remember. The second thing is when the girl reaches a reproductive period, that is, we say the adult life, and she's wanting to get pregnant. In those cases, the lady may also develop infertility, which I will highlight much more after this. She may have early pregnancy loss, where she gets pregnant, but she loses the pregnancies in the first few weeks of her pregnancy, and that usually is due to a hormonal deficiency. And if she gets pregnant, she has a higher risk of developing hypertension during pregnancy or gestational diabetes. The third phase of her life comes when she's 40 plus or she's menopausal. And that's the time when she develops metabolic syndrome, by which I mean she develops dyslipidemia, she may develop hypertension, she may develop diabetes, all the works which happen usually at that age. And then there's a higher risk of her also developing cancer of the endometrium. So these are the various problems which a girl can have right from the time of puberty to the postmenopausal period. And that is why we need to look at what really, at what stage of sort of phase of her life she comes to us. So that is where we have to look at. Now, keeping the fact that I've got 20 minutes to talk, obviously I cannot cover the entire gamut of all the issues which occur with PCOS. But yes, we do have a status where I'll just go back one slide, please. We must remember that when PCOS is accompanied with infertility, it is one of the most frequently observed cause of female infertility and affects almost 10 to 15% of reproductive age women, almost 70% of anovulatory infertility, by which I mean where the woman is not ovulating, occurs because of PCOS. And almost 80% of PCOS women are either overweight or they're obese. So obesity is one issue which is commonly seen in all PCOS right throughout her life, and that is why Dr. Raman felt it is important for us to discuss PCOS today. And this PCOS itself may increase the risk of obesity, potentially by reducing the basal metabolic rate and impairment in appetite regulation. So these are the ways in which a woman who's got PCOS may have issues with obesity. Obese women with PCOS also have reduced ovulation. That means they don't ovulate every cycle, every month. They may get their periods every 2 months, 1.5 months, 2 months, 3 months. So their ovulation obviously reduces to 3 or 4 times in a year. And this is where the problem is, that they have trouble getting pregnant because of this reason. They also have a problem. We have seen, if you have a PCO patient, she may be either obese or she may be lean. Now, 80% are obese, while the other 20% will be either lean or normal weight. And we have seen that even if a woman loses only 5 to 10% of her weight, it will definitely help her to get pregnant faster. And today we are using more and more of assisted reproduction to help such women, so that we can help them to get pregnant faster. Because if they are going to ovulate only once in 2-3 months, they have a chance of getting pregnant only 4 times in a year. Whilst if we have given them any ovulation induction, or we have used any assisted reproduction techniques, we can allow her to get pregnant every month and increase her chances of pregnancy. Now, coming to what really is overweight and obesity, if you see defined by WHO, there are different standards for the international obesity and for Asian Indians. The reason is that for Asian Indians, we find we have a lot of visceral obesity. It means we have a lot of fat, not in the subcutaneous tissue, but internally within the viscera. And that is the fat which is harmful and can cause a lot of problems for her in her future life. So here the cutoff limit is at, as you see, if you see the international obesity, it's considered to be more than 30. Whilst in Asian Indians residing in India, not the Asian Indians living abroad, Asian Indians living in India, the obesity, the BMI cutoff is more than 25. So this is something we must remember. Of course, there are data from different parts of the world. If you read Indian data, and if they have stuck to obesity being less than 25, then you may find that there will be a different result seen in those patients. Now, if you see with obesity, you'll also have insulin resistance, you'll have hyperinsulinemia, and as I explained earlier, it has effects from different areas. Now, what happens when it works on the ovary? It causes a high LH level, but at this a consistent LH level, so which prevents ovulation from happening. And at the same time, we have progesterone levels which reduce after ovulation, and those low progesterone levels do not allow an embryo to implant well, and that is why they may have early miscarriages. So this study, if you see, which is done with PCO patients and who have undergone assisted reproduction, this study was looking at the effect of the BMI on IVF outcomes in fresh cycles. This was a retrospective study done in almost 293,000 patients who underwent fresh IVF cycles. And these were mainly, out of these patients, about 34 to 35,000 of the cycles were related to PCOS. And they separated out these patients based on their weight. So they had a cohort which had a high BMI based on the WHO classification, and they had controls which had a normal BMI. Now here they looked at the outcomes they were looking at as the implantation rate, the pregnancy loss rate, and the live birth rate on all these parameters. And what they concluded was that the success rates and the odds ratio for all pregnancy incomes were more favorable with the low BMI compared to normal BMI. They became worse with increasing BMI. Obesity also added a negative impact on IVF outcomes, which did not reach, of course, statistical significance. But we need to do more research to determine the causes and the extent of influence of BMI on IVF success rates. But definitely in normal patients who are not undergoing any treatment, if you just look at, you compare the lean and the obese PCOS, you'll find that the lean PCOS get pregnant faster on their own as compared to the obese PCOS. So here we have our own experience of our patients. I've put it up over here to see what really we found in our patients of PCOS who are normal weight, overweight, or obese. Now, if you look at the number of eggs we received, the first column is a normal weight and the last column is the obese. If you look that the number of eggs we got with the same standard dose which we use, 14 eggs in the high BMI patients and 7 eggs in the obese, 7 eggs in the obese patients and 14 eggs in the normal weight patients. Similarly, when you compare the other statistics of pregnancy rate, etc., in the normal pregnancy, we found the pregnancy normal weight, the pregnancy rate was about 56%, whilst in the obese patient, the pregnancy rate is 32%. Now, all this is statistically significant. The live birth rate was 52%, and in the obese, it is 27%. That means they're having many more miscarriages as compared to the normal weight patients. The miscarriage rates are higher and the biochemical pregnancy rates are almost the same. So if you see, the missed abortion and biochemical pregnancies are not statistically significant. Then if we look at the weight loss, if we ask the patient to have a weight loss, what is the outcome on the results of that assisted reproduction? And it has been shown through various studies that the first step is to make the patient lose weight so that her ovulation gets back into a normal pattern. Weight loss also helps spontaneous pregnancy rates. Whilst we are telling patients to lose weight, whilst they are waiting for their treatment, they come back pregnant. So even spontaneous pregnancy rates go up. And patients who undergo bariatric surgery are also able to conceive spontaneously after bariatric surgery. But of course, there's a limitation on whom you offer bariatric surgery to. Then, sorry, can we go back one slide? Yeah, no, one slide back. Yeah, so this is the observation which we have made, which has been made from various studies. This is, if you lose weight, how does it help? Now, does abdominal fat matter? I talked to you all about visceral fat. So why do obese women respond differently to fertility treatment? This study, which was done where they compared patients where they compared the role of subcutaneous versus intra-abdominal fat in PCOS women who were not ovulating, what they found is that they could, in both the groups, the age group was the same, the BMI was almost the same, and they found that there was a higher weight loss in patients who were subjected to weight loss. The patients who had a weight loss were doing better. The abdominal fat was also, getting rid of much faster. So here is the comparison of these two groups of patients where abdominal fat is more and abdominal fat is less. So those who had a higher fat, they tended to not ovulate, abdominal fat, and those who had a lower abdominal fat were tending to conceive much later. So the next thing is, we don't keep doing DEXAs to look at abdominal fat. Does just measuring the waist circumference matter? So again, this study where they compared 3 different groups with different waist circumferences, the highest being more than 86 centimeters and the lowest being less than 77 centimeters. And they adjusted all the variables like smoking, etc., etc. And what did they find? They found that the live birth rate in patients who had a waist circumference of less than 77 centimeters was 53%, whilst in women who had a waist circumference which was more than 86 centimeters, they had a live birth rate of 38%. And this was statistically significant. So even if we measure the waist circumference, waist circumference is related to visceral obesity. And this is something we must conclude from this study, that the higher the waist circumference, lower was the probability of live birth among women undergoing assisted reproductive technology, independently of BMI. Whether their BMI was high or no, but if somebody who's even otherwise lean, but she has a high waist circumference, she'll have a worse prognosis as someone with a lower waist circumference. That is what we need to remember. In our own data, we found the same story, that if we found that number of eggs which we got from the waist circumference which was less than 80 centimeters was much higher as compared to the ones with the waist circumference which was higher. The pregnancy rates were better, all statistically significant, pregnancy rate, clinical pregnancy rate, and the live birth rate. So these are the various parameters which even we have noted in our own data as compared to the other data. Now, so coming to the conclusion of my talk, what the current recommendations for obesity are, that the first thing we need to do is ask the patient to lose weight. Now, it's been shown that a weight loss of at least 7% of body weight is required. This they can achieve by doing increased physical activity for a minimum of 30 minutes a day for 5 days a week. They need to take about 500 to 1,000 kilocalories per day decrease from their usual dietary intake. And once they do that, they'll be able to lose approximately 1 pound a week or 1 to 2 pounds a week. Depends on what was their original intake. So weight loss through exercise and through diet is extremely important in such patients. So many obese women who are infertile, that's the first thing we tell them, get rid of your extra weight. Now there are patients who try their best and they just can't manage it. Then they have no choice but then to go further into weight loss programs, maybe to go through bariatric surgery. Obesity in women is associated with ovulatory dysfunction, and therefore there is reduced ovarian responsiveness. Even when we treat them with ovulation-inducing agents, there are many such obese women who just don't respond to the drug. So the only way we can make them respond to ovulation induction is by making them lose weight. So losing weight is extremely important for them. And this is the first line treatment for obesity, followed by adjunctive medical therapy. By adjunctive medical therapy is we give them insulin sensitizers. Because they are insulin resistant, by giving them insulin sensitizers, we are able to help them to lose weight provided they exercise and provided they control their diet. And personally, I find that in such patients, by giving them metformin, it definitely helps them to lose weight, because otherwise they're frustrated, nothing's happening, nothing's moving, and by the time they're so exhausted, they give up. So by giving them metformin, and metformin has been shown to definitely help in their weight loss if they are exercising and if they are eating healthy. So bariatric surgery is the last step which we put a patient onto, because once they go through bariatric surgery, we advise them not to get pregnant for at least a year after that, because of the absorption which occurs and could affect fetal nutrition if they do get pregnant after that. So postponing, but the other fact we have to look at is if a woman is obese and she's just not able to do it, she's not going through any surgery, she wants to go ahead with pregnancy because she's getting older, it has been recommended that there's no need to wait for her weight loss. but you should keep in mind that she's advancing in her reproductive age, and we need to get her pregnant as fast as possible, and then we must try everything possible to help her to get pregnant. So I'd like to use this opportunity to welcome you to join the PCOS Society of India, which is a multidisciplinary organization of all the specialities which deal with PCOS. We welcome you to become a member and log on to our website and see all the academic work here. Thank you very much for having me.
Thank you, Professor Durusha, for a wonderful talk. Just to summarize, it's very clear that 80% of young women with PCOS are going to have obesity of some degree. And definitely with weight loss, they are reproductive and fertility issues will be sorted to a good extent. We will take questions in the end, but I just have one question, and that is, with weight loss, that the fertility improves, but do the other features like hirsutism also improve with weight loss in women with PCOS?
No. The weight loss doesn't affect the androgen levels. It tends to affect only the insulin levels, and we find that patients are don't have a benefit. Basically, it helps them to ovulate well, but the androgen levels have not been found to come down as effectively. They do come down marginally, but not effectively. And the clinical signs and symptoms of acne and hyperandrogenism, they do get little better because the insulin resistance is better. Even that comes down. But with the effect seen on hirsutism, it takes almost 9 months to see the effect, whilst acne disappears faster. So there is definitely a connection between insulin resistance and hyperandrogenemia. You may find that the patients get better with that, but it doesn't help all patients. That's what we have to do.
Thank you, Professor Durusha. Thank you so much. I would now like to invite Dr. Kiran Coelho. She is the Chief Coordinator of the Department of OBGY at Lilavati Hospital, as well as a consultant obstetrician at Holy Family and Hinduja Healthcare Surgical Hospital. And she will be talking about impact of obesity on pregnancy and delivery. So over to you, Dr. Coelho.
Thank you so much. Welcome, everyone. And thank you, Dr. Raman Goel and Docplexus for giving me the opportunity to speak on the impact of obesity on pregnancy and delivery. The hospitals I work, and we know that maternal obesity gives rise to multiple risks for both the mother and the baby. The risks to obese women during pregnancy is increased depression, anxiety, gestational diabetes mellitus, gestational hypertension, preeclampsia, and even a double risk of prolonged pregnancy because the babies are so large. And the risk to the baby is increased congenital malformations, especially neural tube defects, where there's a 2 to 3-fold increase. A lifetime risk of diabetes mellitus, and the 2-fold risk of intrauterine fetal disease, as well as I think just a moment, I need to increase my screen. I think I can't see part of my screen. Is there any way I can?
Yeah, we can see the screen.
No, I can't see the screen myself, so it's just one. If there's any way I can bring it down.
You can go on the...
Yeah. Okay, that's fine. Is that all right?
Yeah.
Yeah, that's much better. So there is also, what is very interesting to note is that many studies have shown that in the late third trimester, after the 39th week of pregnancy, there is a great increased risk of intrauterine fetal death and stillbirths. And also, surprisingly, a spontaneously extremely preterm delivery at 22 to 27 weeks. And this is also with maternal obesity. And of course, these patients are more prone to get induced preterm delivery and also cesarean section. Now, the reason for obesity causing problems is that there's a dysregulatory effect on both the metabolic, vascular, and inflammatory pathways. And therefore, they're more prone to get insulin resistance, preeclampsia, Many of times it is a maternal genotype, that is the inherited gene from the mother for obesity, and the fetal exposure to increased levels of glucose and lipids causing problems with the fetus itself. Now we will discuss the issues during pregnancy, those during delivery, those in the postpartum period, and also for the fetus later on. In the antepartum, we know that there is during pregnancy an increased incidence of pregnancy loss, occult type 2 diabetes, gestational diabetes, pregnancy-induced hypertension, and indicated and spontaneous preterm delivery, and of course post-term deliveries. And during the delivery, these obese women are more prone to have induction of labor. They have decrease in progress of labor. They have a greater chance of having a cesarean delivery, and a trial of labor after cesarean delivery is very often a failure. There are plenty of difficulties with anesthesia, and of course there are complications related to macrosomia. In the postpartum period, these women are more prone, especially since most of them have operative deliveries. They have an increased incidence of venous thromboembolism, infection, postpartum depression, and very often they have a lactation failure as well. In the offspring, there is a greater chance of congenital anomalies, stillbirths, prematurity, large for gestational age, asthma, childhood obesity, and neurodevelopmental disorders. Now, the management could be pre-pregnant and during pregnancy. In the pre-pregnant stage, counseling is so important. So pre-conception counseling and evaluation and care forms an important role in managing these women, because, of course, prevention is better than cure. So we must give them information about the adverse effects of obesity on infertility, the potential pregnancy complications associated with obesity. We must evaluate them at this point of time for obesity-associated medical comorbidities and counsel them about the benefits of weight loss before attempting to conceive. Pre-pregnancy weight loss, of course, cannot be done alone. One must refer them to a dietitian and an exercise specialist. Diet, exercise, and lifestyle change is important. And also adjunctive medical therapy, as Guru had mentioned, with insulin sensitizers, which some of them can be continued during pregnancy and some should not be. And in those very resistant cases, of course, then we have to resort to bariatric surgery. And once there is weight loss, there is a great beneficial effect, as Guru mentioned, in fertility. Bariatric surgery, of course, is the last resort. For women above, you could say 25 BMI with comorbidities. And the types of surgery Dr. Raman Goel will explain. There could be restrictive procedures which decrease the stomach capacity, like lap or sleeve, and malabsorption procedures like gastric bypass, which decrease the absorption of calories and nutrients by shortening the functional length of the intestine. The effect of this immediate rapid weight loss and improves fertility. But what is very important is that these women should not be allowed to under pregnancy for at least 2 years after the surgery, because the patient should be allowed to achieve full weight loss, and the fetus should not be exposed to rapid maternal weight loss environment. And also they have malabsorption syndromes which affect the nutrition of the patient during pregnancy. Now, in the pregnancy management, I'll divide them into first trimester, second trimester, third trimester, and delivery and labor. Now, in the first trimester, baseline assessments are very important, because maternal weight, mass, and body index should be recorded at the time of a first consultation. Blood pressure, we have to get special cuffs because the regular cuffs will not work on these patients. Early ultrasound is very important, number one, for dating the pregnancy and also to rule out multifetal gestation, which is very common among obese women. A medication review of what the medication she's already taking, and if she's on anti-hyperglycemic drugs, then some can be continued. The ones which cannot be continued and have to be changed in favor of insulin therapy, so a diabetologist should be consulted. There should be a diabetic screening and also screening for liver function tests and renal function tests, because we know that obesity is a known risk factor for non-alcoholic fatty liver disease or NASH. And of course, for those patients who have undergone bariatric surgery, we must evaluate and treat the nutritional deficiencies in the first trimester. Now, in the first trimester, counseling again is very, very important. Counsel for the pregnancy risks, and of course, diet, gestational weight gain, exercise should be reviewed frequently, and also we should take the help of a dietitian to help these women during the entire pregnancy. Now, how much weight gain does a woman put on during pregnancy? The normal weight, a woman with a normal weight and not overly obese, 7 to 11 kilos in the entire pregnancy. So the first trimester, there's weight loss, and there in the second and third trimesters, right up to the 30 weeks, there is a weight gain of 1 pound or half kilo per week. Now, in a patient who's already obese, ideally we should cut down this weight gain, but practically it is not possible. And also we run the risk that these women then would have low birth weight babies or intrauterine growth restriction babies. So therefore, we just have to ensure that she puts on the right amount of weight, that is 1 pound per week or half kilo per week, and not more than that. So that is the goal for weight gain in the obese maternal patients. Now, in the first trimester, exercise, of course, what she has initiated pre-pregnancy, she can continue. So we do not tell the patients to stop exercising in the first trimester, and she can continue with the exercise programs throughout, right up to her delivery to control gestational weight. Now, what is very important is the fetal genetic testing or aneuploidy screening. We do it for all patients and obese women also. Now, we know that obese women are not at increased risk for fetal anomalies, but the testing can be difficult. For example, if we do the NIPT test or serum-based screening test, they have to be adjusted for maternal weight, and that results are not so accurate. And to see the nuchal translucency and diagnostic procedures like amniocentesis and chorion villus sampling are a little bit more difficult in these obese patients, and therefore they are challenging to do. Now, the reference, of course, in the first trimester, if there's underlying cardiac disease, pulmonary disease, they should be referred. If she has obstructive sleep apnea, they should be referred. And, of course, a dietitian and a diabetologist to have a group therapy for these pregnant women. Now, also, we come to the second trimester. Now, low-dose aspirin is indicated in these women because with a BMI of more than 25 or 30, there is a moderate risk factor for preeclampsia. Therefore, giving these women low-dose aspirin from the second trimester up to the delivery is definitely indicated, especially other moderate factors where there's nulliparity or where there is maternal age more than 35 or previous bad obstetric history. Low-dose aspirin is definitely indicated. In the second, again, we have to do an ultrasound survey, and a detailed 3D anomaly scan should be performed between 18 to 24 weeks. But due to the limitations of ultrasound with the increasing because of the weight, then we also should do a quadruple marker test at this point of time to rule out congenital defects and screening for neural tube defects. Maternal obesity is not an indication for fetal echocardiography unless the detailed obstetric ultrasound assessment of the heart was not optimal. Now, screening for gestational diabetes should be done on her first admission, and then definitely recommended between 24 to 28 weeks of gestation. And of course, we can do any of the methods, like 75 grams oral glucose tolerance test or the 50 grams one, and should be monitored again in the third trimester as well. Now, in the third trimester, assessment of fetal growth by mere clinical examination is difficult. So a serial ultrasound examination is indicated. So we would like to do one at 28 weeks, 32 weeks, and then a detailed one at 36 weeks with a fetal monitoring. Assessment of well-being, of course, throughout pregnancy. After the 36 weeks, we would like to do an NST or electronic fetal monitoring of the fetus from 36 weeks right up to the top term, because these babies are known to have macrosomia and also sudden fetal death in the last trimester. Now, let us see management during labor and delivery. When we deliver an obese mother, we have to have the equipment and the instruments ready in the labor room. Proper BP cuffs, large size operating room table, labor room, gowns, etc. Fetal monitoring, sometimes external continuous fetal monitoring may not be possible, so fetal scalp electrode may have to be used. And of course, anesthesia consultation is very important because of the higher risk of anesthetic complications in these patients. So timing and route of delivery is important. Very obese mothers, usually because of macrosomia, because of we have to induce them at around 39 weeks of pregnancy, do not allow them to go beyond that. So because of induction, because of the other obstetric indications also, they are more likely to have a cesarean section. And this induction early is to reduce the stillbirth complications. When we have a cesarean delivery, of course, we have to give thromboprophylaxis, pneumatic compression devices, and also injections, and antibiotic prophylaxis. Technically, of course, I won't go into this, but they are more prone to get post-operative infections because of abdominal fat. So this has to be taken care of. Now, in the postpartum period, because especially if there's an operative delivery, they should be ambulatory much earlier because they have chances of post-operative infection, they have deep vein thrombosis, and they should be encouraged breastfeeding. They can give additional support because many of them have a failure of lactation. And women with gestational diabetes should be screened for glucose tolerance after 6 to 12 weeks of delivery. So there we end with management during pregnancy and labor. And I was asked to also give a brief talk on obesity and cancer risk for women. Now, being overweight can cause these types of cancers, and the most important of which are breast, bowel, and uterine cancers. Studies have shown that there's convincing evidence that obesity leads to as a predisposing factor to endometrial cancer, postmenopausal breast cancer, and probably ovarian cancer. Now, the promotion of cancer in obese, why do obese women are more predisposed to cancer is because of the carcinogenesis of the endogenous sex hormones, insulin resistance, hyperinsulinemia, and the formation of adipokines, cytokines, and chronic inflammation. So obesity leads to insulin resistance, increased estrogen, adipokines, and we are later on leading to carcinogenesis. So endometrial cancers are the 6 most common cancers of women and the most common gynecological malignancy in the developed world. Studies have shown that there's a significant increase of cancer in mild obesity, 2.6-fold increase, moderate obesity, 4.7, central obesity, 2-fold increase, and early life obesity, there's a moderate increased risk of endometrial cancer. The mechanisms are, of course, prolonged exposure to unexposed estrogen and hyperandrogenism, insulin resistance, chronic inflammation, and adipokines. Now, this very busy slide shows us the biology is excess obesity to the endometrial cancer risk, which we have already discussed earlier. And the second is breast cancer. The most common breast cancer among women, especially in urban India, is breast cancer. And the relationship of breast cancer risk differs by the tumor characteristics, the menopausal state, and also exogenous hormone use. So it's not purely due to obesity. And obesity has opposing effects on different periods in a woman's life. So in a menopausal woman, obesity in childhood and during adult life, there's a decreased risk of hormone-dependent cancers, breast cancers, due to a reduced exposure due to endogenous progesterone. Now, endogenous progesterone or progesterone supplementation is the cause for early cancers in premenopausal women. And actually, obesity, it helps these women. But in a postmenopausal woman, increased risk of hormone receptor positive disease or ERPR positive is supported by the hypothesis that estrogen is the crucial link. And after menopause, adipose tissue is a major source of estrogens, and obesity is associated with higher estrogen concentration, which in then have tumor promoting activities and may explain the higher breast cancer risk in these patients. And weight gain in postmenopausal women increases the risk of postmenopausal disease, and it is limited to those women not using HRT and hormone receptor positive disease. These are the mechanisms linking adiposity. You have adipose, the hormonal effects, the formation of adipokinins, and increase in hyperinsulinemia, and then increased level of estrogens, resulting in increased breast cancer risk. And what is interesting to note that obesity results in poor breast cancer specific survival, irrespective of menopausal status or the hormone receptor status. If a woman is obese, she has a poorer lifetime survival rate. Ovarian cancer is the seventh most common cancer, but studies have shown that there are not very convincing studies to show that obesity increases ovarian cancer. There's only a moderate increase in premenopausal women of certain histological subtypes like low-grade serous and invasive mucinous tumors. So it's not a strong risk for, so obesity is not a strong risk for ovarian cancers. And the mechanisms, of course, are the same. Cervical cancer, of course, we know 99% of them are not related. They are due to human papillomavirus, and there is a very modest association in some of the studies with adenosquamous cervical cancer. So therefore, obesity is as an avoidable cause and the attributable risk for endometrial, postmenopausal breast and colon cancers. And 2/3 of cancers are attributable to obesity. I think breast, uterus and ovary, they have been associated with many studies with high BMI. I think that's all, and I'd welcome questions. Thank you.
Thank you, Dr. Coelho, for that wonderful presentation. Very clearly summed up the different antepartum, intrapartum, postpartum difficulties faced in obese pregnancy, as well as the cancers like endometrial and breast cancers, which are more common. We will take questions at the end, but I just want to ask you one thing, one very basic question. In your practice with obese or morbidly obese women who are pregnant, is the chance of performing cesarean more versus the normal weight women? So do you have to do more of surgical deliveries in them?
Yes. Yes, definitely, because 2-3 things. If they are morbidly obese, or even if they have a BMI more than 35, studies have shown, and also my clinical practice has shown, that after 39 weeks of pregnancy, the chances of having intrauterine fetal death and sudden stillbirths are very high. So we usually induce these patients. Many of them have comorbidities of gestational diabetes, preeclampsia. So these patients also have to be induced earlier. So therefore, earlier induction results in increased chances of cesarean section. Also, macrosomia, or large babies, and associated comorbidity increases the chances. So I would say definite increase in chances of cesarean section for obstetric as well as maternal reasons for these patients. And therefore, the chances of vaginal delivery are less.
Thank you so much, Dr. Coelho. We'll take the questions at the end. Now I would like to invite Dr. Raman Goel, the Director of Center of Metabolic Surgery. He's also the President of IAGS, to take his talk, and that is going to be a role of bariatric surgery in obesity and women diseases. Sir, please take over.
Yeah, thank you, Amrit. Before I start my talk, I would like to thank both the experts. It's heartening to hear we have been reading in the books, but to know from the gurus who have been dealing with PCOS and pregnancy on a daily basis, and some of the senior most persons in Mumbai, has been very heartening and to know. And they have made my job easy, because they have highlighted how obesity has its impact on women across the ages. So as Dr. Durusha rightly pointed out, that it's not only about the adolescent girls who have PCOS. When they have PCOS, it has its impact right even after menopause. And Dr. Kiran Coelho has very rightly pointed out. So I'll quickly start my presentation. I'll share my screen and try to highlight how bariatric surgery helps women. All right. So So thank you all the participants for joining us on a weekly basis on Friday 4 p.m. So I'll start right from few guidelines, which says that with lifestyle modification, only 15% are able to maintain their weight. So the basic issue of any management of PCOS or obesity related issue is that whether lifestyle changes are effective. And when I say lifestyle changes, they primarily mean diet and exercise. And this is a challenge because most of the patients are able to lose 5% to 7% of their weight, which is good enough. But if they are able to maintain it, primarily for all PCOS management, it is a good idea to think of initially managing all patients with lifestyle changes. Only very few patients who are indicated to have bariatric surgery should be undergoing bariatric surgery. But in morbidly obese patients, as the slide shows, the Australian guideline shows that bariatric surgery is an effective means of weight loss, and most women may resolve PCOS signs and symptoms. What has happened even more that in Australian guidelines, they have indicated that even for lower BMI, girls and women who have PCOS, bariatric surgery may be advised because they are associated with metabolic syndrome. So when the metabolic syndrome is there, the PCOS benefit is only partial with 4-5% weight loss, and if bariatric surgery is done, the benefit is substantial. Similarly, the European Society of Endocrinology has also said that those patients who have metabolic syndrome and the women is obese, then bariatric surgery should be considered as part of treatment. And it changes everything. It changes the hormonal profile. It reduces the heart attack or cardiovascular risk, and improves the pregnancy outcomes, which have been so nicely highlighted by Dr. Coelho. Now, one of the things is that a lot of our young people or girls who are planning to get pregnant, they are trying to use a very low calorie diet, and there is evidence to say that they may lead to poorer outcomes of infertility treatment. So a balanced diet, a gradual weight loss is probably better if somebody is thinking of a lifestyle changes. Otherwise, VLCD should not be done. There are lower adverse maternal outcomes in pregnancy after bariatric surgery, which is almost brings the outcomes are almost at par with somebody who is a normal weight pregnant women. I'm not going to talk about bariatric surgery per se, but these are the commonly done procedure. The sleeve gastrectomy is done in almost 60% patients countrywide, and the other two bypasses are done 50%. That means about 20% each. Contrary to the popular perception, this standard bypass is not a malabsorptive procedure. So the sleeve and the standard Roux-en-Y gastric bypass are only restrictive procedures and does not cause malabsorption. Only the third type of bypass, which is a newer bypass, causes malabsorption and is a matter of concern if somebody is going to planning a pregnancy. There are even endoscopic procedures like a balloon or a sleeve gastroplasty, but they may not have a long-lasting weight loss and should not be encouraged in a morbidly obese person. But a person who is just overweight and is suffering from PCOS is not able to conceive, probably the endoscopic procedures could be a good choice for them. As far as weight loss is concerned, we are able to provide very substantial weight loss, as our own publication shows. This was that after 1 year, with sleeve, patients on an average are able to lose around 87% weight, and with bypass, they are able to lose 97% weight. 97%, and this is all extra weight. And after 3 years also, they are still almost 72% down, while almost 86% down after bypass. So substantial weight loss and sustained weight loss is what bariatric surgery provides compared to just a lifestyle change. So briefly talking about how surgery affects PCOS, Dr. Durusha has explained this in detail, but there are studies which says that that even if the person loses only 5% weight, there is a benefit in PCOS. But this is difficult to achieve and difficult to maintain on lifestyle basis. This you should compare it with the 10% weight loss which is achieved in very first month after bariatric surgery. There is this study, which is a meta-analysis of 13 studies of more than 2,000 patients, shows that in these patients, 45% patients had PCOS before surgery. In this group of 2,000 patients, at 1 year, only about 6.8% had a PCOS. And same way, infertility also reduced from 18% to 4.3% within a year's time after bariatric surgery. So bariatric surgery, because of weight loss, because of hormonal changes, and because of multiple other parameters of controlling metabolic syndrome, helps in improving the hormonal situation in a woman. There is also an Indian study from All India Institute from Delhi, where they had 18 women with the PCOS, and they said at 1 year the patients lost about 63% of their extra weight. All patients regained their normal cycles at 3 months, and hirsutism, which is hair growth that was being discussed earlier, resolved completely in about 44% patients. So as madam was right, hirsutism does improve, but it may not go away completely in some patients. And the male hormones, the testosterone decreased, and 55% patients had complete resolution of polycystic ovaries at 1 year. And metabolic syndrome, which puts the woman at risk of heart attacks or brain strokes or other problems, resolved completely at 1 year. So this is seen in Indian patients as well as in Western population. Bariatric surgery primarily works by reducing the insulin resistance. In our own study done at Bombay Hospital from 2008 to 2010, which was published subsequently, we have shown 90% reduction in insulin resistance within 6 months. And this is a common feature between PCOS and diabetes. Both of them, this is a common issue of insulin resistance. It's also important to understand that though women seek help for their irregularities and hair growth, it's a good time, good opportunity to test them, to educate them that this is a symptom of a metabolic abnormality. It is not just a cosmetic issue if somebody is having hair growth, or it's not just a period issue that they are not having periods, but this shows an underlying metabolic abnormality, and these women at this time can be forewarned that they should be careful so that they don't have these problems. And the same way Dr. Coelho said, they can have cancers later. So it's a good idea to make sure that these women understand this. And these women who are morbidly obese, or who are, let's say, 30 BMI and above, they deserve to be offered education and counseling regarding role of bariatric surgery. They may not get it done at this stage, but they can choose a time later if they wish to. Just to show you this young girl we operated in 2012, has had no periods for almost 3 years, and now she's almost 8 years down the after surgery, absolutely a healthy person, and lost 60 kgs. Now about infertility. So this is from a study where patients came for bariatric surgery, and in 40% of them, the major concern was infertility. So they are not coming just for cosmetic purpose or for diabetes control. 40% of them are coming for infertility purpose, and 30% of women below 45 years, they had a major concern about pregnancy in future. So both issues were there, that whether whether the infertility will get resolved, and those who are not infertile, 30% of them were worried that whether the surgery will impact their pregnancy in future. So what about fertility treatment? So there is reduced need for fertility treatment within 3 years of bariatric surgery. So somebody who has been going for IVF and other fertility treatment, that requirement will go down. And it has been seen in studies, these are all references, that conception without ovulation induction agent is possible once these women lose weight or they undergo a bariatric surgery. There is another major study where they have done 110 patients with obesity and infertility. They did bariatric surgery. 69 of them became pregnant. And they said that even a drop of 5 BMI points, it's not 5 kg, 5 BMI points, was a significant predictor of fertility within 2.5 years of surgery. So I think, and the type of bariatric surgery, whether it's sleeve or a bypass, does not have any impact on the fertility outcomes in these women. Now, what happens when they go for IVF cycle? So this study has shown that in 18 women who are undergoing IVF cycles before bariatric surgery and after bariatric surgery, and the study has shown that there is significant reduction in treatment cost. They require fewer injections, and thus the patient is comfortable, and there is no adverse effect of bariatric surgery on the number of oocytes. So there is a reduction of BMI from 43 to 29 after bariatric surgery, and this is the impact on IVF cycles. There's another study which says they're done only on 5 patients. It's like a case series. They said out of 5 patients, 4 of them conceived within 1 to 2 cycles and gave to full-time live birth. I just wanted to show this lady. She's very open about her. She doesn't mind that we share her pictures, but we have blocked her identity. She was 39-year-old when she was referred by IVF center from Delhi. She had already undergone 3 IVF cycles and was not able to conceive. We operated her, and 1 year later, after the mandatory period of avoiding a pregnancy, after the very first IVF cycle, she conceived. And this was pregnancy after 26 years of her marriage. And I still remember she called me from the labor room. She said, after my husband, you are the second person I am calling you to convey the good news. I know obstetricians are quite used to getting such calls, but for bariatric surgeon, this was a unique experience. Now about pregnancy, how bariatric surgery affects pregnancy. So this is a study of comparison of 288 pregnancies in women after bariatric surgery. There was improvement in hypertension and diabetes, decreased cesarean rates, decreased length of labor, and decreased neonatal birth weight. We all know in obese women, it's possible that the child will be overweight, and if they undergo bariatric surgery, that possibility reduces. Now, this controversy about waiting duration, that a woman should wait after bariatric surgery. Now, this is presumed and logical that every woman should wait for at least 1 year to avoid getting pregnant during rapid weight loss and metabolic changes. And this is the recommendation of American College of Obstetricians and Gynecologists also. But there is a study which is published where they have 104 pregnancies in less than 1 year, mean 7 months after the bariatric surgery. And they compared it with 385 pregnancies with the same age group and similar BMI who also conceived. These are operated patients and who waited for 1 year. So more than 1 year and less than 1 year. And they found there was no difference in maternal complications, fetal outcomes, or delivery complications. I'm not suggesting that you should not wait for 1 year. Actually, every woman should wait for 1 year. But if accidentally somebody gets pregnant at 6 months, 7 months, one can, and it's a precious pregnancy after, at a senior, in an elderly woman, one can probably look at this study and continue the pregnancy in such situation only. Just to show you this young girl, we operated about 10 years back, and she was 121 kgs, married, and maybe around 3 to 4 years later, she got pregnant spontaneously, and she delivered a healthy baby. And she said that her pregnancy was healthiest among her obstetrician said that her pregnancy was the baby was healthiest and pregnancy was uneventful. Now it's important that it's to realize that after bariatric surgery, there may be unexpected spontaneous pregnancy, and that can happen because the hormones normalize very fast. And it is important to realize, because this woman who was not able to conceive earlier is very, very excited, and it could be quite tricky, because if she conceives 2 months after bariatric surgery, you may not like to continue the pregnancy. So it's a good idea to discuss contraception in every bariatric patient, even if she's infertile or even if she's not having period, so that the first 8 to 12 months she doesn't get pregnant. Now, what happens to the child's health after bariatric surgery in women who were morbidly obese, underwent a bariatric surgery, and then they delivered a baby? It has been found that adult obesity is approximately 50% less in children of bariatric mother. And this has been studied beautifully by Dr. Yajnik from Pune, where he has shown that it is not only one generation when the adult becomes normal weight, they have shown its impact in next 2 to 3 generations. So I think losing weight is so important to restore health in the family for next 2 or 3 generations. There are many other benefits. I'm just limiting to 1 or 2. Since Dr. Coelho mentioned about cancer today, she spoke about cancer. There are long-term follow-up studies. So this has been seen that in women, the number of first-time cancer was lower in bariatric surgery group than in those who did not have a bariatric surgery, substantially different. But this benefit is not seen in men. So for once, women are at advantage, and primarily because of the hormonal issue. So the bariatric impacts hormones, and the hormone-related cancers, which Madam has mentioned earlier, substantially improved after bariatric surgery. There is another, the last issue that I want to discuss is urge incontinence. Now, a good number of our bariatric patients who come to us have to go to the toilet many times at night and sometimes during the day also. This disturbs their sleep, and this is because of the visceral obesity. The bladder is compressed, and they have to get up 5-7 times at night to empty their bladder. And many of them have very bad knee joints, so they find it very difficult to walk to the toilet or to sleep again. And these women are substantially benefited with bariatric surgery, because their visceral fat reduces, bladder capacity automatically expands, and they are able to sleep better. So I think these are the issues which have to be seen. I wanted to put take-home messages, but then I saw this position statement of American Society of Bariatric Surgery, which has also been endorsed by American College of Obstetric and Gynecology, which says obesity is associated with delay in conception. Obesity reduces male fertility parameters. So whenever infertility is being assessed in an obese woman, please look at the husband also, because if husband is also obese, then he may be having a problem. The symptoms of PCOS are exacerbated in presence of obesity. Weight loss can improve PCOS and insulin resistance related infertility. Lower probability of live births after IVF in obese. This has already been discussed. Bariatric surgery achieves significant and sustained weight loss. Pregnancy is not recommended during the rapid weight loss phase after bariatric surgery. And counseling and follow-up regarding contraception during this period is important. So practically, this is the summary of all the 3 talks that have happened. And I would just end up with this picture of a woman who came from South Africa for this surgery. She had none of these so-called women's issue, but the kind of psychological impact a surgery has when the appearance changes. She says, I look like my own daughter now, and the quality of life has improved substantially. I have worked for 16 years as an associate professor and have been associated with the obstetric and gynec more than my bariatric colleagues at Kama Hospital. And I know how difficult it is to manage these patients in obstetric, in labor rooms, and in operation theaters. So thank you so much. And I'll be happy to take the questions as they go. Amrit, you have to unmute yourself.
Thank you, Dr. Goel, sir. You have summarized it quite perfectly and made a lot of things clear in our minds. Before I take the question, just one question for you from me. We are stressing so much on not getting pregnant in the first year after surgery. So is it to do with the pregnancy outcome, or is it to do with the weight loss in the mother? How does it, like if the mother gets pregnant, say in the 5th or 6th month, does it affect her weight loss?
Yeah. So both. Scientifically, most of the publications say that the recent publication says it doesn't affect. But primarily, we are worried about fetal outcomes. As far as mother's weight loss or weight gain during pregnancy is concerned, there are now scientific publications which shows that pregnancy's impact on hormones or the body overrides the impact of bariatric surgery. So a lady who becomes pregnant in 3 months will stop losing weight and will gain the kind of weight that Dr. Coelho has mentioned, 7, 8, 10 kgs, even if she's eating less. So the hormonal changes of pregnancy overrides the hormonal changes that come with bariatric surgery. I'm not concerned about her weight loss. I'm not concerned about weight loss because after delivery, most of these women are able to continue losing weight because the hormonal influence goes away. We are more concerned about the fetal outcome, that there should be no malformation because of reduced nutritional intake. So I think that is what it is. Yeah.
Thank you, sir. Thank you, all the speakers. We'll just take the questions one at a time. This question is for Professor Durusha. And the question is, can a person with hypothyroidism get PCOS, and are they related? Is there any relation between hypothyroidism and PCOS?
Yeah, we do actually see much more hypothyroidism in PCOS women as compared to women who are not PCOS. So on an average, I think almost 7 to 8% of my patients with PCOS have hypothyroidism. So the thing is that we must make sure that the hypothyroidism is, if it is existing before the PCOS, we need to first correct the hypothyroidism. Make sure that after correcting hypothyroidism, if still the periods remain irregular, then only we can label them as a PCOS patient. So there is a coexistence, no doubt about it. It is definitely more common. And I think it's more like an autoimmune system, which is with women who have got more of antithyroid antibodies, we see more of PCOS. How it is connected, we are still not very sure. It's not very clear.
Thank you, ma'am. There are a couple of questions which are quite similar. I would take them to Dr. Coelho, which you have kind of covered. What are the adverse fetal outcomes associated with maternal adiposity? What are the congenital abnormalities commonly seen in obese pregnant women?
Well, I'll take the second question first. Neural tube defects are more common, and multifetal pregnancies are more common in obese women. But otherwise, aneuploidy itself is not increased in these pregnant women. It's mainly, and it is associated with lower folic acid and lower vitamin B in these obese patients, and that is why neural tube defects are more common. Then, of course, fetal macrosomia, prematurity. These are the complications for the fetus with pregnancy-related obesity. And I also wanted to add on to Dr. Raman Goel's that in my experience, I have delivered many patients who have had their bypass surgery, and 3 of them conceived within 6 months of the surgery. And my chief concern was they automatically in the first trimester patients will lose weight. But malabsorption was not a problem. Their hyperemesis was, all of them had hyperemesis. But my main problem was iron deficiency anemia after the second trimester, because most of them, they cannot tolerate iron orally. So I had to give them, towards term, I had to give them intravenous iron. So these 3 patients, but otherwise, I've had many patients who have conceived following bariatric surgery, and many of them have had even normal deliveries. I've had no problems, except for these 3 patients who had conceived soon after. Yeah. And therefore, giving them contraception also, you have to give them only barrier contraception. You can't give them hormonal contraception. That's one thing we have to keep in mind.
I completely agree, ma'am. We also had a lady who was not having periods before bariatric surgery, and she did not have it for 6 months. And then she started feeling that she's putting on weight, got a sonography done, and she found she's pregnant.
Right.
So she continued because she was already almost 5 months pregnant. So probably she got pregnant at 1 month after surgery, and there was no event. But I think it's a good idea to avoid neural tube defects in babies, to get folic acid levels checked before somebody is planning a pregnancy after bariatric surgery. So that's an indicator of overall nutritional supplementation. If folic acid is less, folic acid obviously should be supplemented, but there's a surrogate indicator whether the person is taking their supplements adequately or not. Yeah.
Thank you, sir. Thank you, ma'am. Sir, one question for you. Suppose a patient undergoes bariatric surgery who was earlier suffering from PCOS. You said that it takes some time for cycles to regularize. So how much time would you say should the cycles take to regularize, or should the person continue the PCOS treatment after surgery?
That's not easy to say, because it will depend on the severity of the primary problem, the PCOS. We just saw this study from All India Institute, which they said that all the women, all 18 of them they had a regular periods at 3 months. Okay, because surgery in the first month itself gives 10% weight loss. If somebody is 150 kg in first month, you can prognosticate 15 kg weight loss, which is much better than what lifestyle changes give overall, and that is known to cause benefit. So I think, let's not say this, but generally we tell these women that you need to wait for at least 3 to 4 months. Periods may be irregular or may not be there. And after 3 to 4 months, because of surgical stress also, the periods may be altered. And after 3 to 4 months, if they are not regular, then they must meet their primary gynecologist and take their treatment advice. Yeah.
Thank you, sir. There is one more question. It's more of a general question, which first Professor Durusha can address. What is the importance of addressing obesity issues in women? What is your opinion? The importance of addressing obesity issues in women?
I think the address should start even during childhood. It's well known that if children are obese, they tend to become obese adolescents and obese adults. So in short, right from childhood, we have to prevent obesity, because everyone knows that obesity is associated with so many issues which are health related, especially the onset of diabetes, onset of metabolic syndrome. And in our country, diabetes is almost the world capital, and therefore we need to be more aware of being obese. We need, because as we have discussed today, I mean, forget only PCOS, but obesity itself adds on to the problems of PCOS. Similarly, as Dr. Kiran has mentioned about obesity and pregnancy, there are so many complications. So in short, we have to look at all the problems which a woman can have because of obesity, and therefore even quality of life issues. I mean, women who are obese, they don't feel comfortable. They feel they have many issues, when they go out. So I think health-wise, quality of life-wise, every possible way, I think obesity is a big no-no for everyone, whether they are women or they are men.
Yeah. Dr. Coelho, your views on importance of addressing obesity issues in women?
Absolutely. It's as Guru mentioned, obesity, polycystic ovarian syndrome, diabetes mellitus, these are the India is the capital of the world, especially urban India. So all of them are lifestyle all of them are lifestyle conditions. Bad habits of eating, irregular sleeping habits, a lot of stress, strain, all that leads to all these metabolic symptoms. So therefore, looking after your weight is the primary. What comes first, the weight gain or the PCOD, we don't know still. But weight loss definitely is the most important aspect. And I find so many in my practice, so many practitioners giving young girls who come with, they've not lost their puppy fat, they are young adolescent PCOS. They may have very mild PCOS. And just a lifestyle modification, just diet and exercise, and they would not need any medication. So giving long-term medication to these young girls, except if their periods are delayed just to get a withdrawal bleeding, is fine. But to put them on hormone treatment right from the beginning without actually addressing their weight loss is very wrong. And these young girls should be told that if they lose weight with diet and exercise properly, then their periods will become normal and they can, come out of this polycystic ovarian and obesity. Obesity during pregnancy, I've already mentioned. And obesity, as Dr. Raman Goel mentioned, in the menopausal women, at menopause, either fat women become fatter and thin women become thinner. That usually happens. Now, if obesity in the postmenopausal women, they have not only urinary incontinence, but they have stress urinary incontinence. So often, almost 1 out of every 3 obese women in their perimenopausal, because now estrogen is less, their ligaments become loose, and they have stress incontinence to which giving them such a low quality of life that many of them can't travel without sanitary pads. They can't travel abroad. They can't, and traffic in Bombay, if God help them if they are in a traffic jam with this urinary incontinence. So that also gives rise to very poor quality of life.
Thank you, ma'am. I think we have covered most of the questions. Sir, some final words from your end?
Okay, I think I'll just continue with the obesity issue that was discussed just now by both of them. I think obesity, besides the health issue, at the moment, we are also talking of what is happening with COVID. So we know obesity and diabetes are 2 high-risk factors, and there are more deaths happening in persons who are obese and who have diabetes. So I think that is a emerging situation and an emergency at the moment. But having said that, in our practice, because we see extreme obesity, I have seen, just because we are emphasizing on treatment of obesity, the parents should not take it among themselves to make their children lose weight. I have seen parents coming with a young girl just because she is not getting married, that she goes to gym 2 hours in morning, she goes to gym 2 hours in evening, and still she's not losing weight. We don't know what is she eating, where she is eating. This is just the way we are obsessed with education in our children. We should not be obsessed with obesity. If you want your children to lose weight, parents should be the role model. You should start exercising, you should eat healthy way, and then you don't need to tell your children what to eat and how to exercise. So I think obesity stigma is a big issue in Western countries, but it is an unrecognized reality in our country. And each one of us is responsible that people within our family, our friends, and distant relatives also should understand this issue. Because obesity, as somebody said, senior endocrinologist says, has a potential to bankrupt this country, because the obesity causes diabetes, obesity cancers, obesity causes hundreds of problems, more than 200 diseases. So I think we are running this series on obesity, and we will have different issue covered every time. And so I would thank both the experts today. And over to you, Amrit.
Dr. Raman Goel, may I ask you a question?
Sure, ma'am, please.
The new procedure of endoscopic sleeve gastrectomy, how effective is it?
Yeah, ma'am. So I just mentioned it during my presentation. So generally, this leads to about 15% weight loss, or let's say 10 to 15 kg weight loss. Okay. So it's good for people who are not morbidly obese. Somebody who is just overweight, say 28 BMI, 29 BMI, cannot undergo a definite procedure. And it's more of a cosmetic in nature, that the person wants to look slimmer, is planning to get married, and neither can get a bariatric surgery done nor is able to lose with. So I think all these endoscopic procedures are good in a certain category of patients. Same procedure in a 150 kg patient is a failure, because with 115 kg weight loss, it doesn't help the patient at all. Rather, patient will get more frustrated. So it has a role to play, but in certain category of patients, and we do perform these procedures in those patients. Yeah.
Thank you.
Okay. Thank you so much, sir. I would like to thank Professor Durusha, Dr. Kiran Coelho for being with us today, and Dr. Raman Goel. Thank you for your valuable inputs. Our next session will be next Friday, 4 p.m. and that time you will be discussing diabetes and obesity, another extremely important topic. So from all of us here, thank you for joining and take care.
Thank you.
Thank you.
Thanks for having me.
Thanks.